So, as people are coming on, though, I wanted to introduce the star of the show, our Carolyn Lenz. Carolyn is a licensed mental health counselor and national board certified counselor who's certified as a trauma-informed chair, yoga instructor, and certified trauma-informed yoga Nadira instructor. She's currently working with the Suncoast Center as a clinical manager of the Trauma Services Program and Outpatient Program, and she also is a therapist herself. She's worked in the human services field for various capacities over the past 15 years. Some of the roles include a CPI investigator, a foster care adoption caseworker, managing group homes, as a behavior analyst, as a grief counselor, a substance abuse counselor, a foster parent, an in-home counselor for trauma service survivors, and a private practice therapist and school counselor. So she's got a lot of experience doing a lot of this work and experiencing both the effects of trauma as well as the benefits of resilience that we're going to be talking. A common vein through all of these various roles that she's mentioned is a passion and a commitment to working with vulnerable populations. She's passionate about raising awareness about trauma and supporting staff to provide the best possible. And so, without further ado, I introduce Carolyn Lenz, who is here to talk to you about trauma-informed care.
Great, thank you so much for the warm introduction, Doug. And I'm really excited to see that we have over 180 participants. That's wonderful. And so we're going to go over, as Doug said, talking about what is trauma-informed care, why is it important, how do we do it? So let's get started. Okay, so as I mentioned, the purpose of the training is to learn about trauma and the impact that that can have on a person, to learn about the principles of trauma-informed care, how to implement it, and why it's important to use trauma-informed care. We're going to highlight a few agencies who are currently implementing trauma-informed care practices and give you guys some concrete tools that you can use to help take away from this training and be able to apply it in your work. And then also, we're going to talk about understanding resilience, what it is, why it's important, and how we can promote it.
Carolyn, I'm going to interrupt you real quick. Can you talk a little bit louder? We have a couple people who are asking to either talk a little bit louder or individuals, please turn up your speakers.
Yes, I will do that. Okay, so let's first do an overview of what trauma-informed care is. So the basic principles of trauma-informed care is having an awareness of trauma, having in mind safety for the people that we serve and also for the staff, choice and empowerment throughout any services that we provide, and then a strengths-based approach. And I want to reiterate that as we're talking about trauma-informed care, these might be things that you as an individual are going to implement, or that you could take back to your organization and create policies and procedures around really being able to use this in a broader scope. So the first video we're going to watch talks about some of the core concepts of trauma-informed care, some beginner steps of how to implement it, and why it's really important. It does talk in the video about using trauma-informed care in a medical practice or a doctor's office. So if that's not the setting that you work in, what I want you to do is to focus more on the broader concepts of what they're discussing, which is why trauma-informed care is important and how we can take those tools back to any practice setting or even as our own individual doing this work and be able to improve outcomes for the people who we serve.
The old saying, don't judge a book by its cover. Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the U.S. than you'd think. In fact, 60% of U.S. adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
I really like that video. I think that it gives a good overview of some of the core concepts of trauma-informed care. And so I really want to emphasize that becoming more trauma-informed care as an individual or an organization doesn't have to be a painful process. We can start in small ways or big ways. And just like it says in the video, it makes a huge difference in how our clients are doing, how our staff are feeling in their work. And so we're going to really drill down on some of these concepts as we're here today talking. So before we go any deeper into what is trauma-informed care, I think it's important that we all get on the same page about what is trauma. Trauma is a word that I hear thrown around a lot as a part of our culture, and saying things like, "Oh, I went to the DMV, it was horrible, I'm traumatized." And what we probably mean was it was really stressful, it was painful, but it wasn't necessarily traumatic. So to make sure that we are all understanding the same idea of what constitutes trauma when we're talking about trauma-informed care, or we're talking about the adverse childhood experiences, we're going to use the DSM-5 diagnosis, or definition rather, of trauma. So the DSM-5 is the Diagnostical Statistical Manual, and it's what any licensed clinician or person in the field would be using to determine what is the criteria for a diagnosis, and how to be able to label that. So in the DSM-5, trauma is defined as an actual or threat of death, serious injury, or sexual violence. So again, it could be the actual event of being exposed to a feeling like your life is in danger, feeling like you may be seriously injured, or that you may experience sexual violence. It could also be being aware that that's happening around you or to someone who you care about. And it can also be the threat for someone saying or acting in a way that causes a person to perceive as if their life is in danger. They may seriously be injured or they may experience sexual violence. So there are other significant things that people go through that obviously don't constitute trauma under this definition. So things like losing a job, divorce, those can cause a real impact on a person's emotional, psychological well-being. And I don't want to minimize the impact of those things. We know that stress can be bad, can be detrimental to a person when it's pervasive or it's overwhelming. People who are exposed to high levels of stress or chronic stress often have a lowered immune system. They have increased adrenal functioning, which can cause all kinds of challenges and difficulties coping often. So knowing what we know already about stress and how we feel and how people around us feel when they're under serious stress, I want you to take that and really amplify it in understanding how someone might feel or react if they were experiencing one of those events that would constitute trauma. Within trauma, we can break it down even a little bit farther and talk about little t traumas and big T traumas. So a little t trauma is a smaller event that still constitutes trauma, but it's singular. It's not as impactful as some of the what we'll call big T traumas when we get there. So a little t traumatic event could be, for example, if a person goes through a period where maybe they're having difficulty making ends meet, they're not getting enough to eat, they're worried about being able to, where they're going to live, how they're going to be able to keep themselves safe. And then that lasts a few weeks or a few months, they get back on their feet, they recover. And that experience of being without food or being without a safe place where they can sort of cope with things could constitute a little t. Another little t example would be a person who hears gunshots in their neighborhood. They never see anyone get shot. They never see anyone brandish a gun. They never see direct violence. But hearing those gunshots, they're able to understand that there are people in my vicinity who are using weapons. Potentially someone is getting shot. I could potentially get shot. And that could constitute a little t type event. A big T is a singular traumatic event that has a much bigger impact. So that would be something like actually seeing someone get shot or being held at gunpoint or experiencing domestic violence, or even that, for example, a child who on the other side of the wall, they can hear their parents in domestic violence and they know that person is getting injured or being raped, and that closeness of the relationship of the area where the violence is happening could constitute a big T because it's closer and it's more impactful due to the real danger of that situation. So people could have any combination of these. They might have one little t, they may have 10 little t's, they might have a combination of big traumatic events. It could present in any kind of way. But it's helpful for us to really understand what exactly trauma is defined as. And we'll talk a little more about how that presents as we move along. So here I have kind of broken down some of the different types of trauma that a person might be exposed to. And obviously this is not an all-encompassing list, but it'll help us to kind of conceptualize some of these different types of trauma. So we're going to start here on the left where we have acute trauma. So acute trauma would be a singular traumatic event that is time limited. And when we talk about acute, we're thinking about like a 30-day window for when a person has experienced some type of traumatic event. And within about a 30-day window, they're experiencing some stress or adjustment related to that. To the right, we have chronic trauma. Chronic trauma is the experience of multiple traumatic events. So this could be somebody has a really bad year, so to speak, where they experience multiple traumatic events, and that would constitute chronic trauma. And we could also be talking about across a person's lifespan. and maybe they experienced some of those adverse childhood experiences like domestic violence or having a parent or caregiver incarcerated, not having stable housing, and then other events that they experience as an adult or as they're developing over the course of their life. So we know that when people have more than one adverse childhood experience or traumatic event in their life, it tends to have a more cumulative effect on how they are able to relate to the world and the psychological impact of having multiple traumas. Down at the bottom left is complex trauma. Complex trauma is the exposure to chronic trauma and the impact that such exposure has on an individual. So when we're talking about complex trauma, we're starting to really look at or talk about a person who has experienced multiple traumatic events over any period of time. And then we're starting to see some lasting changes in how that affects the person. So they may have difficulty with feeling safe. They may have difficulty with being able to function in their day-to-day life. We often will see with complex trauma changes in people's cognitions where they start to perceive things like the world is not safe or I can't protect myself. And as a professional, we might feel like, well, this person isn't trying. They act like they're helpless. But for them, they're perceiving the world through the experience of having had multiple traumas where maybe they couldn't protect themselves, or maybe there was nothing that they could do. And that sort of then bleeds out into how they perceive themselves in the world without necessarily making that connection or being able, even if they make that connection, being able to do anything differently about it. With complex trauma, we could be talking about someone who meets full diagnostic criteria for post-traumatic stress, or it could be that we're seeing other things going on with them. They may have substance abuse, they may have anxiety, depression, all different kinds of presentations. But really what we want to start thinking about is how that complex trauma and the way that it presents is the impact of having survived these experiences. On the bottom right is system-induced trauma. So system-induced trauma is the trauma that an individual or a group could experience when they try to access services. So the system could be any number of things. It could be interaction with the juvenile justice system, with the being incarcerated, being involved really with the judicial system at all. It could be involvement with child welfare, or child protection. It could even be trying to access services for mental health care or medical care. But essentially, when a person is involved with one of these systems, and they may or they often experience additional trauma because of having had negative interactions with a system of care. So this is really important for us because we have the potential to intervene here and both to help people have healing experiences when they are interacting with our systems, and to see that not every system is going to treat them badly or abuse them or be a traumatic experience when they try to navigate that system. And we also have the ability to be able to help people when we can implement trauma-informed care to be able to really understand the importance of, both as an individual and an organization, that we create practices and policies that help to support people's recovery. Like it said in the video, to become a healer. And that's really why we're all here, is because we want to help people. So in the first video we watched, it talked about the adverse childhood experiences, which is when before the age of 18, an individual experiences abuse, neglect, housing instability, having a family member or a caregiver incarcerated, having someone in the home who abuses substances or has untreated mental health, quite a few different ones. This is a way of looking at the ACEs that's a little bit different. If we just give someone the ACEs questionnaire and they check off yes and their score is an 8, then what? So how are we going to use that to help us? looking at the pair of ACEs is really a more integrative approach because it looks at both the community environment and exposure to those adverse childhood experiences. And then it conceptualizes how a person who's facing those challenges would develop, or the challenges that they would have to overcome in order to develop into a healthy, flourishing person, versus someone who didn't have those early or community environmental adversities. And I think that this is really important because there's been a lot of talk lately, and I hope that it will continue, about the race disparity, about economic inequity, about communities that have food scarcity or access to healthcare, and what a difference that makes in people's lives. So here, if we're looking at this tree, and in your mind, you can imagine that this tree represents a person. So a tree who's planted in this community, the ground and below is kind of the foundation, so to speak, that if they are in an area that has increased poverty, increased discrimination, housing, good housing, no housing, violence, lack of opportunity even. There's areas of our community where there's not a lot of jobs and people turn to other things that might be looked at as, poor choices, but they are doing what they can to be able to survive and provide for themselves. And then at the top, we have those different things that would constitute ACEs. And I do just want to highlight, it does say maternal depression, but really having anyone in the household who deals with untreated or mental illness that's having an adverse impact on themselves and those around them. So you can imagine how a tree who's planted in this environment, although it could grow healthy, it has to work so much harder to do that than a tree that's planted in an environment that is full of nourishment and has all of the ideal conditions. So something to think about is, what is the community that I live in? What does that look like? What does the community or the environment for the people who I serve look like? What are the challenges that they're having to overcome that can really be a challenge for them and can impact the way that a person is developing, accessing services, interacting with the world, and feeling about themselves or their ability to meet their needs? I also want to just reiterate about the frequency of adverse childhood experiences. So the CDC estimates that in 2019, they surveyed, of the people who they surveyed, 61% of adults reported that they had experienced at least one of those adverse childhood experiences. And keeping in mind that any of those, having even one, like it talked about in the video, can really have an impact on a person's development physically and emotionally over the long term. 16% of adults reported that they had experienced 4 or more adverse childhood experiences, and 5 of the 10 leading causes of death are associated with ACEs. Things like heart disease, obesity, suicide are all associated with having more ACEs. So thinking again about the connection of how these early experiences or even experienced traumatic events later in life, how that can have a lasting effect over someone in ways that we may not even realize or they may not realize. And so by being more trauma informed, educating ourselves, educating the people who we're serving on how those things may have impacted them in ways that we can work towards healing can make a huge difference. Okay, so next we're going to watch a video by Dr. Burke Harris. If you're not familiar with Dr. Burke Harris, I would really encourage you to look her up. She is an incredibly intelligent and inspirational person. She is a physician who practices in the San Francisco area, and she's going to talk a bit about how her work with adverse childhood experiences has shaped her practice and improved the the outcomes for the people who she serves by using trauma-informed care. And again, this is talking about a doctor's practice, but I really want you to attend to the things that she's saying about the lasting impact of adverse childhood experiences or traumatic events, the ways that she implements trauma-informed care practices, and the improvement that that had in the people who she serves and in the well-being of those who are providing the services.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed.
Okay. There's so much good information in that video, that talk from Dr. Harris. Every time I see it, I take something away from it, more away from it. And you can kind of see how when we are not trauma informed, we could look at the people who are challenging, who might be presenting for services as having those bad behaviors or being unmotivated. But when we look at the bigger picture of the impact that trauma, or even if it's not trauma, that adversity can have on the development and the long-term function of a person, it just is such an incredibly different shift. And one of the really important things with trauma-informed care is making that mental switch between looking at a person and thinking, what's wrong with you, to what's happened and what can we do to support you. So now that we've talked a lot about the impact of trauma, we understand about how that can really manifest over time and change a person's physical or emotional well-being. Let's talk a little bit about what trauma looks like when it presents, physical, psychological, all of that, so that we can really start to identify trauma reactions in the people who we serve, or even in our peers and our loved ones. Okay, so first we'll talk a little bit about the reaction to trauma. So as a reminder, the trauma definition that we're using is the DSM-5 definition, in which a person is either directly exposed to or experiences the threat of physical injury, sexual violence. And so when a person is facing trauma, and they are going to develop what we would call a fight, flight, or freeze reaction in response to that. And Dr. Burke talked a little bit about that fight, flight, or freeze reaction, of how our brain immediately reacts to this threat and starts to go into one of these reactions. So fight would be when a person perceives that danger, and then they would respond in a fight way. And that could look like a lot of things. It could be someone physically trying to defend themselves. It could also be someone who maybe suddenly blows up blows up verbally, and you're kind of like, where did that come from? Well, that could be a trigger that brought on a fight reaction. So fight can look like a lot of different ways, but in a way that a person is outwardly trying to defend themselves. Flight is when a person faces a traumatic event and they instinctually respond with a flight. And that is the effort, physically or psychologically, to flee or escape the dangerous event. So that might be someone running away from an attacker. It might be somebody also mentally checking out, shutting down, not responding, and they are psychologically removing themselves in the way that they can. Flight could also be maybe you have an appointment with someone, you think it goes really well, you have plans that you're going to meet again, and they no-show, and you're like, what happened? Not understanding for that person, accessing services or the thought of having to go deeper into whatever it is that triggers them could be causing them to no-show as a part of a flight reaction to trauma. And the last reaction is referred to as freeze. And freeze is when a person is unable to fight, they're unable to flee, then the last resort is that the brain will shut down into a freeze state. And that can be that a person could physically become catatonic, where they don't move. It could be that a person is unable to speak. So sometimes victims will talk about, I didn't say no, or I didn't scream for help. And that was because they were in a a freeze reaction, where their brain and their body literally shuts down in order to be able to survive that event. Something I really think is important to understand when we talk about fight, flight, and freeze is that we don't get to pick how we react. I really want to emphasize that when we are facing traumatic events, we don't get to pick how we react. Our brains will instinctually assess in milliseconds and decide whether it's a fight, flight, or freeze that is going to best give us the potential to be able to survive that event. And I think that's really important because often victims or survivors have a lot of guilt or shame about how they reacted. And they think, well, I should have done this. Or they hear people saying things like, well, I would remember my rapist face, or, I would know how I got there. I would have fought them off. And we all want to believe that. We all want to believe that we would be able to protect ourselves. We would be able to prevent some of these bad things from happening, or we would be able to get ourselves out of those situations. But the reality is we don't know how we would react, and we don't get to pick how we react. So in that moment, instinctually, we respond. And then also past events can also influence the way that we or someone facing trauma would survive or react to it rather. So maybe somebody had a previous traumatic event where they responded with a fight reaction, and that made things worse. They became more injured or dangerous. Then when they're facing a future traumatic event, their brain may default into saying that that's not the best option. And so really just looking at how a person responded, helping them to understand that and to know that that allowed them to be able to survive this experience. Some of the physical symptoms of trauma, there's actually some on here that aren't physical, but that's okay. So it can present in kind of a positive or a negative way, and that doesn't mean good or bad. Positive means that something's being added. So a person is having increased heart rate, restlessness, shaking, crying, inability to sleep, sweating, tension, chills even. Those would all be signs of an increased physiological reaction to experienced trauma. And these could present right in the moment. It might happen later. It could happen at any time, really. And then also people may have a decreased physiological reaction when facing trauma. And that could be things like having difficulty remembering things, difficulty with concentrating. It could be hypersomnia, where somebody's kind of like physically or mentally exhausted and they're sleeping more, decreases in appetite, fatigue, loss of interest or loss in motivation in being able to do things. So my point in showing like, hey, it could really be just about anything, is that it's not our job to assess whether somebody is telling the truth or their reaction is right. It's to understand that these traumatic events can affect people in all different kinds of ways. So also some psychological reactions. So people could be emotionally, psychologically impacted also in a variety of ways. They may experience shock, depression, sadness, confusion, feelings of guilt or shame, avoidance, anxiety. These are all common reactions to trauma. And shock is kind of protects us for a period of time, because what we have experienced is so overwhelming that physically or emotionally we go into shock. So you might see a person who had a recent traumatic event and they may be sort of like, they don't have any big impact. They seem fine. And then a few weeks or months, years later, they start to develop symptoms. And that can be because that shock was protecting them initially from being able to take in all of what happened. Depression and sadness, confusion. In the trauma field, we talk a little bit sometimes about shattered assumptions. Everyone has assumptions about the world, that people will help me, or I am able to take care of myself. Whatever it is, we have these sort of beliefs, and we may not even be aware of them. But then when a person experiences a traumatic event, often it causes some shattering of those assumptions. And that can cause a lot of confusion, shock, depression, all of that. Also just confusion, trying to make sense of why this happened. Why me? Why did I react the way that I did? How could I have prevented this? A lot of that sort of rehashing of things. Self-blame, shame, and guilt are common symptoms that people can be left with following traumatic events. And as peers and professionals who are responding to trauma, it's really important that we're mindful of how we talk and the questions that we ask, because we can accidentally or inadvertently engage in victim blaming, and that really amplifies the emotional pain that people are going through when they're experiencing trauma, or they're starting to try to reach out and connect with the world following having had trauma. So post-traumatic stress disorder is something that we hear probably a lot about in the field, in the news. And so I'll talk a little bit about what the diagnostic criteria is for that, but I really want to emphasize that the majority of people who experience traumatic events do not experience post-traumatic stress disorder. And that does not mean that the minority who do are inadequate or in some way doing something wrong. It just means that the majority of people are able to be resilient or to bounce back from having traumatic events without that having the permanent, or it's not really permanent, the long-term effects of post-traumatic stress. So in order to meet criteria for that, a person would have avoidance, which means that they physically or emotionally try to avoid things that remind them of the traumatic events. So if somebody previously feels like they experienced trauma through a system of care, that can certainly make it difficult for them to be able to engage in accessing services when they could use them or benefit from them. Re-experiencing could be things like flashbacks, having intrusive thoughts related to traumatic events, physical re-experiencing. It could be that a person, had experienced a sexual assault in the past, and when even though they're in a safe, happy, healthy relationship, when they try to engage in intimacy with their partner, they start to re-experience the past assault, and then that can cause a lot of stress for them and their relationship. Hyperarousal is that increased heart rate, feeling on edge all the time, anxious, unable to relax. And then negative changes in cognitions. That's one of the really important parts with post-traumatic stress. And we know that whether a person develops post-traumatic stress or not, having had experienced complex trauma, many people have negative changes in cognition. They feel like the world is not safe, and they know it's not safe because of their experiences, or they feel like they're not able to protect themselves, or they're not able to do the things that they want or need to do. And if you have that belief about yourself or about the world, you can imagine how that's going to impact your ability to be able to get out there and do things. At the bottom is just kind of like highlighting that traumatic responses or responses to traumatic events occur across the spectrum, from a brief period of adjusting to acute stress, where we have for that 30-day period following a traumatic event, someone might be having some of these physical or psychological reactions. And then post-traumatic stress, if someone is, for a period of months meeting all of the criteria of being impacted in these different areas. And then complex PTSD. Complex PTSD isn't currently recognized in the DSM, but it is basically post-traumatic stress syndrome, and the symptoms are very, very severe and persistent, and that a hallmark of that is really strong feelings of shame that kind of permeate everything. And you can, think about how that would weigh on a person and impact their ability to care for themselves, to care for others, to access services. So the last thing that we're going to talk about in this section is really related to us as professionals. So we've talked a lot about ACEs, about trauma, what it is, how it can impact a person. But I want to emphasize, as we're doing this training and as you're taking away this information, that trauma-informed care is not just for you, it's also about how you respond to yourself, how you care for yourself, and then how we take that back into our life and be able to support our peers and create organizations that serve both the staff and the clients more effectively. So you may be familiar with this. Sometimes it's something people have never heard of, but secondary trauma or vicarious trauma is when a person who provides care or is in regular contact with someone who has experienced trauma starts to develop symptoms related to stress and trauma themselves. So as a professional who works with people who may be dealing with chronic homelessness or are involved with the child welfare or there's inequity in the community that causes all kinds of stressors. And although you're there and you're doing what you can, being exposed to that every day can start to have an impact on you personally and professionally. So the first signs would be kind of what we call compassion fatigue. Compassion fatigue is when people feel sort of emotionally and physically worn down from doing the work. They start to feel like they're less effective. They feel maybe overwhelmed or overburdened, that they don't have the resources to be able to meet the needs. And you start to feel kind of like stuck and in a rut and worn out. And we all know that feeling of being like, oh, I have got to get a vacation, or I have got to do something differently. Those are signs that a person is experiencing some compassion fatigue. If compassion fatigue is not cared for, if it's not attended to and addressed, then it will continue to fester and become burnout. And burnout is the symptoms of compassion fatigue, but much more severe. So when a person has burnout, they have really developed the belief that they are ineffective, that their work is ineffective, that the system is broken and it can't be repaired. It's sort of pointless. And people start to really physically and emotionally check out from the work. People who are experiencing burnout have a higher call out rate than people who are not. So they really start to try to space themselves from doing the work because they just can't cope with it. So what the research shows, which I think is really important, especially for people who are, this is related to people serving trauma survivors, is that the majority of professionals who work in regular contact with trauma survivors, that they will at some point in their career experience compassion fatigue. And so I think that's a really important thing for us all to know. And we have to look at, what does it feel like? What does it look like when I'm doing well and when I'm not doing well? How would I know when I'm feeling compassion fatigue, and what can I do about that? And on the other side, organizations that we really have to look at, how are we doing to support the people who are in the front lines working day in and day out with these traumatized individuals? How is our organization helping to prevent compassion fatigue and burnout? How are we keeping the conversation going about compassion fatigue and burnout? And that's important because the research shows that while the majority of professionals working with trauma survivors will experience this at some point, the research also shows that the majority of professionals will feel like, if I'm experiencing compassion fatigue, something must be wrong with me. I'm not doing well. And if I told other people about that, then they would know that I'm not doing well. And that's a problem, because the best thing we can do to address compassion fatigue and burnout is to talk about it, is to provide education to our teams about what that looks like. How do we manage it and mitigate it so that it doesn't become burnout? Because that's when things can potentially become dangerous, because someone is checked out, that they may unintentionally miss something that's really important. They might make a decision that could be, unethical or something like that, because their judgment is really impaired due to their feelings. And so we really have to take care of compassion fatigue and burnout, and create a culture from the bottom up and the top down where we talk about this, we understand it, and we help to manage it. Secondary trauma is a little bit different than compassion fatigue and burnout, because compassion fatigue and burnout occur along a sort of developing spectrum. Secondary trauma can occur just all by itself. So secondary trauma is when a person experiences symptoms of acute stress or post-traumatic stress following being exposed to someone else's trauma. So I can think of one of my colleagues a few jobs back where she was the receptionist, and part of her job was to process the intake documents. We would all do an assess. We would go out, we would assess. This was for community-based trauma counseling. We would go in, we would do an assessment, we would write an in-depth assessment, and her job was to process that and get it into our medical records. And then also when anybody requested records, she would go through the records and make sure that it was okay to release them, that it didn't have other people's names in it and things like that. Well, we started to notice that Rosie was really kind of like blowing up on people. She would snap at people, she would yell, she was just really kind of unhinged, and nobody knew what was going on. This was totally out of character for her. And so it was a very small practice. I think it was 2 people and an office manager and me. So of course I had to sit down with her, with the HR person, and say, hey, we're concerned about you. You don't seem like yourself. What's going on? We really value you and we want to be able to work through this with you. And what Rosie told us was that as she's processing the paperwork and reading through the notes to make sure it's okay to release them, that she's reading about these graphic traumatic events. And that was bringing up all the stuff from her own past. In her childhood, she experienced severe trauma, and she had, closed the book on that and lived a really successful, happy, healthy life. But when she was reading these, it was starting to trigger her. And the way that she was expressing that, without really realizing it, was that she was becoming verbally aggressive. She was emotionally unstable. And those are signs of that sort of fight and flight reaction. When she was blowing up on people, she was triggered and she was going into a fight mode. When she would disappear for lunch for 2 or 3 hours, she was in a flight mode. And so we were able to say, oh, okay, now we understand what is going on with you. And we can make adjustments, we can provide support so that you can get what you need and be successful. So secondary trauma is when we start to develop symptoms of post-traumatic stress or acute stress because of hearing or being exposed to other people's chronic trauma. So it's really important that that's also something that we talk about and that we have policies and procedures in to support staff to offer things like debriefing or EAP services, and to make it okay for staff to talk about how they are being impacted by the work. And it's important for you as a professional to check in with yourself. We all have our own history. Many of us have probably experienced ACEs, and we bring ourselves into the work. So we have to also take care of ourselves and understand when I'm not doing as well and what I can do to be able to get support for that. So this is something that I think is really, really important. It's just as important as the other aspects of trauma-informed care because it helps our professionals, our really good workers, to stay healthy and happy and have long, successful careers, which is what we all really want. So we're going to do a few minutes of questions and answers.
So the first question is just thank you. So Carolyn, thank you for your work and thank you for sharing this information. The next question is from Barry Altman with FPP Coalition. And he says, I had poked around this topic a year or 2 ago on behalf of FPP, wondering, hoping that somebody had pursued the impact of ACEs on how people achieve levels of financial capability. In simple terms, do adverse childhood experiences or adverse trauma experiences impact how we make money decisions in our lives? My hunch says yes, but I'm unsure if there's any science out there that has sought to prove or disprove this causality.
That's a great question. And I have not personally seen research regarding the connection of financial decision-making. However, I think we could generalize based on what Dr. Burke-Harris discussed regarding decreased impulse control, difficulty with some of the decision-making, things like that, that could certainly affect a person being able to think long-term or delay gratification or any of these things that are a part of making financial decisions. So yeah, I would be interested to see the connection in hard research though.
Very nice. The next question is, what would you say to people who work in an organization that's not equipped with informed traumatic care staff, who work with folks that have experienced trauma, on how to best help them now that they know more about this subject?
Yeah, well, I would say that I'm glad that you're here because I'm hopeful that you'll take some of this information back with you and share it with other people. And we're going to talk next about some of the, details of how exactly to do trauma-informed care. So I hope you'll leave with some tools that you can take back to your organization. But also, I think it's important to know that you, as a lone practitioner, can implement trauma-informed care policies, that you can start with the way that you talk to people, the way that you perceive people, and be able to start implementing trauma-informed care anywhere that you are. And so that's a great jumping off point that you have control over.
Very nice. The next question is, can a person develop the ACEs over time and not necessarily bring them from childhood experiences?
So yes, I would say that a person could develop ACEs or could be exposed to ACEs in childhood, and that may have a long-term effect over them. It could also be that symptoms could present later. And then also people can experience traumatic events in adulthood that maybe, ACEs is looking specifically at childhood, but we know that also someone may have had a perfectly happy, healthy childhood, and then they experience a traumatic event or multiple traumatic events, and that can have an impact on how they cope and relate to the world.
Very nice. We got 3 more right now. One that says, I see the presentation's being recorded. I'd really like to share with others at work. I feel confident I can at least answer that one. Yes, the webinar is being recorded, and we will share with everyone the efforts of that recording after this session. And so the next one that I definitely can't answer, so I'll throw it back at you, Carolyn. Just out of curiosity, is there a difference between in-depth assessment versus a mental health evaluation?
Sure. And those are both kind of general terms, I would say. But anything that has evaluation on it tends to be sort of diagnostic, so that we're evaluating the impact, or is there a problem here, things like that. An in-depth assessment could be more of just getting a history. And when we do an in-depth assessment versus like a biopsychosocial, which is briefer, that the in-depth is going to cover a lot of things like childhood development. How old was a person when they walked, talked, substance use assessment, all different areas that really kind of gives a very detailed picture of a person's life. Whereas any kind of evaluation could be more focused on a particular point and trying to assess that or evaluate that specific thing.
Very nice. The next question is, Dr. Burke-Harris talked about the stress response system. She said that when a bear comes home every night, the stress response system is constantly activated, moving the person from adaptive and life-saving response to, and then they missed what they said after that. So can you finish that sentence?
Yeah. So what she was talking about is when the bear comes home every day, a person is living in that fight, flight, or freeze reaction. And you can probably think about a time when you were under extreme stress, maybe a traumatic event, but definitely serious stress in your ability to be able to process information, to function day to day, and how that could really cause a problem if you were in that mental, emotional state all the time. So what Dr. Burke-Harris was saying is that there are effects when someone is chronically exposed to that can be adverse.
Very nice. And then we have a question that was added just now, so I'll ask the question. But before I do, I also want to throw our eyes to the chat, in which someone threw in a link about a compassion fatigue. They said that they take a compassion fatigue test quarterly to check in how they're doing.
Awesome.
So anyone wants to jump in the chat to see that. But the next question is regarding ACEs. What ages constitute adult or childhood?
Yes. So the ACEs is particularly scoring from age 0 to before a person turns 18. So all of the research on ACEs would be up until a person turns 18. But like I said before, even after adulthood, people may experience those events, which would constitute trauma and could still have an impact on a person over the long term.
Very nice. Well, those are the questions that we have right now, but please, everyone, continue to be asking questions, continue to bring them up. We're going to do a couple more Q&As as we move forward. So again, thank you for staying with us, and back to you, Carolyn.
All right, great. Yes, thank you so much. Those are great questions. I'm so excited to see that there's so many people on this call today. And so I'm really hopeful about being able to expand our reach in trauma-informed care in our community. So next we're going to talk about the specifics of how we do trauma-informed care. And what we're going to start out with is a video by Tonier Kane. If you're not familiar with her, I strongly encourage you to look her up. She is so inspirational and amazing. Tonier Kane is a child abuse survivor. She experienced multiple adverse childhood effects. She dealt with addiction, homelessness, involvement with the judicial system for 19 years. And she's going to talk in this video about her experiences of how those early experiences of trauma impacted her, how experiencing trauma as an adult impacted her, and her interaction with various systems of care.
Well, as a child, I was sexually abused. Married off to an older man at a very young age, experiencing domestic violence. I was a victim of neglect and abandonment by my mother. So I was always treated like I was worthless. And this is how things supposed to be happen in my life. And I needed to find a way to cope with my reality. I mean, at age 9, I was experiencing sexuality that you're not even supposed to. Who do that to a 9-year-old? Moving into foster care, taken from foster care by my mom just so she can marry me off to an older man who beat me constantly. I needed to find a way to cope with that, or I would have killed myself. And I used drugs and alcohol to do it. Unfortunately for me, it introduced me to different public health systems. In a mental health institution, I was always thrown into seclusion. One of the worst things you can do to somebody that's a victim of neglect and abandonment. One of the worst things, because that's how I was always treated by my mother. And now you're going to do it? So when someone come with their trail medication or trail food, I smacked it out of my face, because the only thing I know to do is to tap into my survival mode, because no one has taught me to do anything different. No one has identified, addressed, or treat my trauma, so I do the only thing I know to do, and that is to tap into my survival mode. And my survival mode has always told me to fight, because I didn't know there was any other way. So I did what I had to do to cope, and sometimes somebody might got hit with the tray when I smacked it. So now they're calling a code and they're throwing me down to the ground, restraining me, a rape victim, holding me down and restraining me. Somebody that has been held down and raped multiple times, doing more harm, causing more trauma, but because my chart says that I'm a crazy crackhead. The stigma, that's what they go by. That's what they go by. And unfortunately, I was re-traumatized, taking me even further away from the possibility of healing and recovery. I was a desperate child, still trying to tell somebody what happened to me. Still trying to find somebody safe enough to tell what happened to me. You know, we go to these facilities and they give us these tidbits of good information, but most of us have so much trauma packed so tightly, the bits and pieces of information can't get down there to get rooted. We got to get the stuff out of us so we can get the good stuff in us, so we can change our belief system, because once our belief system change, our thought process change, and we start to make the best decisions in our life. We can't do that if you still believe that we're a crazy crackhead. 2004, I was in prison with my daughter, and I was terrified I was about to lose another baby. I didn't know how I was going to do that. And they kept telling me about a program that addressed your trauma and help you with your addiction and your mental health. I said, well, I'm all those things, and I'm pregnant. And but you know what? I still didn't really have that. I didn't have high hopes. I did it because I wanted to keep my daughter. I didn't do it for anything else, because they sent me to so many different programs, one where I was court ordered and the drug counselor raped me. So how do I believe that anything would work? Really? You court ordered me to a program where I graduated and I was doing well, and then when I went back for aftercare, the counselor raped me. So I really didn't have high hopes after 19 years of going in and out of the systems that I could do better, but all I could see was me trying to keep my daughter. And when I walked through the doors of Tamar's Children, somebody said, "I'm so glad you're here." After 19 years of people shaking their head in disgust at me and just saying, "You're just a crazy crack kid," and hurting me over and over again, somebody told me they were glad to see me. And yes, they did. They dug deep and they worked with me one-on-one to help me to deal with what happened to me, not what was wrong with me, but what happened to me. And they did it right. And it was a one-stop shop because understanding that I was homeless, they made sure I had a housing grant. They made sure somebody was attached to the housing grant that came out and visit me once a week to help me to create a budget and make sure that I was taking care of the property and my daughter. And I was okay with that. Some women say, "Oh, they all up in my business." I needed somebody to be up in my business. And they weren't judgmental. They understood and they helped me. Truly breaking the cycle, because that's what the real picture is about. Yeah, treat my trauma or, remove the stigma to keep me out of your system. Yes, love that. But did you know that doing that was going to break the cycle for my daughter? She would be able to be given what she was given as a result. So we look at a whole different path from here on out for my daughter and her kids and their kids. I got to understand that it's a lot to do with what happened to an individual and how people were raised up or trained up. And then I could understand my job is try to educate them to remove the stigma, to understand the impact that trauma has on the individual. So instead of taking it on that, "Oh, you guys are awful." Well, don't get me wrong, I tell them when they're awful though. But I also know that where there's breath, there's hope. Where there's breath, there's hope. Everybody has room to get better. I'm a living proof of that.
Well, Toni Ricane is an inspiration, and her story of what she went through as a young person and an adult is incredible. And it could be easy to think that it's extreme, but unfortunately, there are so many people who could say that that's my story too, as far as experiencing multiple traumatic events over the course of a lifetime and having additional trauma pounded on top of that through systems of care. And so, the way that she was able to overcome that is amazing. But one of the things, or the thing that made the difference for her, was that first professional who was able to see past her bad behaviors and be able to see what is happening. What have you been through? And I am so glad that you're here. I want to support you. I care about you, and how she was able to start moving forward. And so that's really an inspiration to me, to know that each one of us can make that difference for someone. You don't know how incredible it is for someone who's really fragile on the edge to be supported and seen as a whole person. And some of the really important points, I think, that she made is a change in belief system. She had beliefs about herself that kept her stuck in that life. And then as she was starting to be seen and supported by a professional, her beliefs about herself started to change, but also our beliefs about our capabilities to be effective, and our beliefs, the way that we see the people who we are working with, that change between what's wrong with you to what's happened to you. And then also the way that we're raised up and we're trained up. I don't think you can say it better than that. To really understand that a person's background is going to make an impact on the way that they are as an adult or a child for that matter. And the way that we're trained up is also going to make a huge difference in how effective we are and the way that we can accomplish being there as a support for people. So let's talk about some of the ways that we can actually implement trauma-informed care. So we sort of touched on in the beginning that the core concepts of trauma-informed care is a trauma awareness, focusing on safety, focusing on choice and empowerment, and utilizing a strengths-based approach. So we're going to watch a video next that's from several different practitioners who in different organizations are using trauma-informed care. And some of them are in medical practices, some of them are in more of a social support role, but again, focus on how they are implementing those processes, how they're using trauma awareness, what are they doing to be able to create and support safety for their team and also for the people who are getting services. And what are the ways that they really use choice and empowerment as a part of their practice and the difference that a strengths-based approach can make. And afterwards, we'll go through and kind of rehash or drill down a little further on some of these different concepts.
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma-related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're gonna end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
But what we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
That video always makes me feel really energized and optimistic. And so I really enjoy seeing the different ways in a healthcare and a social service setting that people are on their own individual way implementing and benefiting from trauma-informed care, both with their clients and as their own person feeling more effective. And then also really seeing that it is anybody can start using this, regardless of whether your organization is here and on board or you're here as a sole provider, to really look at, we can all make a difference. So let's talk a little bit more about the concepts of trauma-informed care. So the first one is trauma awareness. So it's really important for us to know our own history and to own our own history, to be responsible for how that is going to impact us, and to be motivated and to do the work of taking care of our own selves also. And then we also want to look out in a broader perspective at what it is that other people have been through and what the impact might be on them. So providing psychoeducation on trauma is really important. That's all part of why we're here, so we can learn and understand more about trauma. But it's also important that we educate the people who we're working with, whether that's our peers, whether that's our client, so that they can understand like what happened to you and why that's resulting in you having these sort of physical or emotional reactions. I've heard many people tell me, I don't know why I keep doing this. I don't know why I keep going back through this cycle that I don't want to be in. Well, it's part of that trauma reaction. And so helping them to understand it and then to be able to make a different response with the support of us or whomever is in their support system. So another way to really take advantage or use trauma awareness is to use some universal screening tools. There are things like the ACEs screening tool, which are just simple yes or no questions. We do some screening with people throughout the course of treatment, but it's important if you're going to do trauma screening that you do it with the purpose that it's going to help inform treatment. We don't want to ask someone how many ACEs they've had and have them go through that questionnaire and then never do anything with it, because that can bring up things for people. We also want to make sure that the person, if we're using screening, who's doing those screenings is trained to be able to answer questions or respond if the person has some emotional, physical reaction to that. Listen without judgment. So one of the people on this video who's a part of the ACEs task force talked about being dictated to. And that can sometimes happen in our work where we know what to do and we have the resources and we're telling people this is what you need. And we're not really looking at what's that like on the other end for the person who's receiving our services. So really making sure that we are listening without judgment, monitoring and managing our own beliefs about what's going on with others, and keeping that open mind for whomever it is and giving them a space where they can be listened and respected and cared about. See if there's anything else that I would add to that. I think also with trauma awareness is something that's important is to know when and where to get help. So we all have our own training in this field, and we should know what our scope of practice is. So if I was a caseworker whose job was to help with housing, I want to know where to refer someone to counseling or psychiatric services if they're really having a lot of trauma or mental health symptoms. And for me, myself, to know what are my triggers and when is it okay for me to go and get my own help and support, whether that's talking with a supervisor or seeing someone outside of my organization, spending time with my friends, whatever it is, doing the things that we do that help us to keep and be energized. Next is safety. Safety is one of the core concepts in trauma-informed care. So I want to emphasize that when I say safety, I mean safety for everyone involved. Our work should be physically and psychologically safe for the person who's receiving services and for us as a provider. So really maybe take some time after this and think about, is my environment physically and psychologically safe for people who are getting services and for myself? And if there's things that you identify that maybe aren't so much, what can be done about that and to try and address it. Another thing with safety is really to try to minimize the power differential between the people who we are interacting with. Sometimes, I catch myself saying to a client, well, call me if you're having a difficult time, or come by the office. And that's really on my terms, that they're going to call me and if I'm available. So making sure that when we talk about safety, that we're creating the environment that is accessible for everyone, that someone who maybe can't leave their house because of their trauma symptoms or their obstacles otherwise, that we're creating a way for them to be able to safely access services. Another thing with safety is to be open and transparent about what you can do and how you will do it. Meet your client where they're at, accept people where they are, and sort of assume that they're doing the best they can with the resources that they have. Explain a rationale behind why you can or can't do something so that people understand where you're coming from. Another way to incorporate safety into your work is to ask permission. So to ask a person what their preferences are, or to ask a person, rather than just saying, well, here's the places that you can contact for housing, of asking, well, I've heard some other resources that people found helpful. Would you like to know about that? Instead of us just dictating to people. Create a crisis plan, for yourself, for your organization, that if things were not safe physically or psychologically, how that should be handled and what the response expectations are. And then after any of these events, making sure that there's a plan in place on how to support people, to debrief, to be able to follow through and assess everything that happened, to figure out what contributed and what changes, if any, can or need to be made. And understand behavior as communication. Sometimes we can get caught up in our work, that we have our appointments, we have our things we have to do, and we're going, and we don't pay as much attention as we should to the cues that people could be giving us that they're not doing as well. So one of the things that Tony talked about is this professional who smiled at her and said, I am happy that you're here. I'm so glad that you're here. So just taking a moment to be able to pause, to greet someone, to assess how they respond can really help you to be able to work in a way that's safer for you and for them. If that person responds with a scowl or they don't respond at all, then I'm going to be thinking about, do I really want to go back to my office alone, or maybe I want to sit in the conference room, or different ways. So we're really being more conscious throughout our work of how people are responding and how they're being impacted, so that we can work in a way that's safe for us and them. Another thing with safety is knowing the resources. You don't want to take on sole responsibility for being able to help someone who has complex challenges. So really making sure you know who are the peers, who is your support system, and the people and the places that you can get support for, and also where you can refer other people so that they are able to access services in addition to yours, where they're not going to be re-traumatized and they're going to be treated with the same respect and compassion that they would when they walk through your door. So some additional tools for trauma-informed care. Oh, I feel like I skipped one. Okay. So we kind of went over trauma awareness and safety just now. So the ACEs is another scale. I think I talked about that you could use for screening. There's also a resilience scale that goes along with the ACEs. The ACEs study did not include a study on resilience, but we're going to talk at the end of the presentation about resilience and why it's important. And anytime I'm going to do the ACEs with someone, I'm going to also do a resilience scale with them, because the ACEs can be kind of difficult. More than 60+% have at least one ACE, and then many people have 4. I know the first time I did it and I checked off all of those things, and I had more than 4, and I was like, wow, I feel like crap. And there wasn't a lot of processing with the person who had me do that screening tool to talk about why I asked you about these traumatic events, how this is going to help me. I was just kind of left feeling like, God, I'm really, messed up. And that just confirms what I already knew. So we really want to make sure when we do those screening tools that we are explaining to someone why. And then we're also looking at what are your strengths that allowed you to be able to survive such challenging and overwhelming experiences. And so that's really a better way to do it. And it is a much more trauma-informed approach. I have here another one for the safety that I didn't mention before is healthy boundaries. It's really important for us as professionals that we understand what it means to have healthy boundaries and that we exercise those with the people who we work with. And I think it's also important to understand that people who have had traumatic events or who have had adverse childhood experiences, they may not have those healthy boundaries because a big part of, for example, abuse or sexual violence, which is one of the traumatic events in the DSM, is someone else not caring about how this is impacting the other person, of not being concerned about how it's going to physically or emotionally harm this person. And so the people we're working with who have experienced these traumatic events, they may not understand or be able to practice those healthy boundaries yet. So for us to understand them, to be able to communicate and educate on that, and then for us also to be able to maintain healthy boundaries ourselves so that we're not too overwhelmed by the work. So the next section with trauma-informed care, a core concept is choice and empowerment. So we want to be sure when we are working with people, whether this is someone who you supervise or this is your client, that we are focusing on choice and empowerment as a part of our trauma-informed approach. So we want to work with people rather than working on people. It's not our job to fix people. It's our job to be there with them, help them understand what they've been through, what they're going through, and to help them find options that are viable for them, and then for them to be able to exercise those options and move forward. So we really want to communicate that we have a belief in the client's resilience despite adversity. And that's kind of like what I was saying with the trauma, is that we want to understand what happened, but we also, and why or how that impacts a person, but we also want to focus on that despite this, you have resilience and you have strengths that have allowed you to survive that, and that can help us to be able to build on and move forward into an even stronger place. For ourselves also, understanding that our clients have the right to make choices. They have the right to do what fits for them. They are the expert on their life. I might be an expert on therapy, which I don't think I am, but the client is the expert on what works for them and doesn't work for them and what has happened to them and what they've been through. So really working collaboratively with the person. We always want to communicate respect, and I don't think you can really fake respect. If you are judging your person, whether that's like I said, a peer or a client, that will come through. And people who have experienced trauma have that hypervigilance a lot of the time. They are very tuned in to little cues that someone is potentially dangerous or is dangerous physically, emotionally. And they might even misinterpret some cues because of that lens. So we have to really go above and beyond to communicate that we respect them, we want to collaborate with them, that we want to work with them and not work on them. So always offering choices and providing services in a variety of different ways so that people can access it in a way that's safe for them, that's functional for them. So, me saying, oh, stop by the office might work for some of my people, but other people who would have transportation obstacles or fears about leaving the house, that doesn't really empower them to be able to utilize services. So instead, being able to say, well, we can call on the phone, we can do telehealth, you could come by the office. There's a variety of ways that we can access services. What sounds like the best option for you? We want to ask about what they want and need, and then we want to really respect those preferences and those limitations and work to help them overcome limitations if it's a possibility. Always offering choices. Even if I'm going to suggest a resource, I'm always going to first ask that person, would you like to hear about this? So, I'm aware of some resources in the community. Would you like to know about that? Or to say, well, tell me all of the things that you're considering as options, and then being able to walk through each one with the person instead of just assuming that I know what they want or need and telling them here's the resource and sort of not really involving them in the process. The last key concept is strength-based approach. And a strength-based approach is really a core aspect of trauma-informed care. It's understanding the trauma and the way that it impacts a person, and then being able to identify that despite that, this person still has strengths. And you may know a lot of times when people are coming in for services, they're feeling beat down. They are feeling like they are not doing a good job or they're not a good person. And sometimes even having someone highlight their strengths or like, it took a lot for you to come here today. I'm really glad that you're here. That can create such a shift for the person of feeling like seen and appreciated that can change the whole dynamic of how that interaction is going to go. So really believing and looking for strengths in every single person. And also, acknowledging that it goes so far to be able to tell people that you appreciate them or you see the good in them. And that is something that I think not just our clients, but all of us can benefit from. So really making the point to notice and highlight strengths that individuals have. We also want to understand the strengths and resources in our communities. Although some of the communities we are serving have a lot of challenges and there's a lot of inequity in those areas that make it difficult for people, there's also a lot of strengths. There is this, network amongst people or somebody who really goes above and beyond at a particular organization. So for you, it's important that you know these different resources and that you're able to utilize them to help balance the work and also to get people resources they can access in the future, and that really empowers them. You yourself as a professional, also, I think it's important for you to know your own strengths. And that's a big thing with being able to combat compassion fatigue and burnout, is when we start to feel like I'm not effective. So really thinking about what are the things that I'm good at, what are the things that maybe I could develop more in, and taking the time to acknowledge strengths that you see in yourself or that you see in others. And again, making this a part of our culture as a person and as an organization, that we really take a strengths-based approach. And that's not to overlook limitations or challenges. It's really to look at, yes, but there are also these other things that are still going for you. So next is the 4 R's of trauma-informed care. And so these are ways that a program, an organization, or an individual who wants to be more trauma-informed, things that they would want to encompass in their work. So the first R is realizes. And in order to do this, we would realize the widespread impact of trauma and potential paths to recovery. So the first part of that is that we realize the widespread impact of trauma. I think we've kind of driven that point home, that the majority of people have experienced at least one traumatic event before the age of 18. If we were to do an ACEs study across the lifespan of how many adverse experiences or traumatic experiences, that would be even higher. So there are people in this room who have ACEs. There are people in your neighborhood, in your community, in your workplace who have ACEs, and that really can impact a large area of how they think and feel and function. And so by understanding that, we really are better able to, or realizing that we are better able to serve individuals. The second part is the potential paths to recovery. I think that's really important, that we don't take a one-size-fits-all approach. So what helped me isn't necessarily what's going to help my coworker or my client or my sister to be able to deal with a traumatic event. We really want to understand from that person's perspective, what have you been through? What is that like for you? And let's talk about different ways that we can work together to help you to feel better, and really looking at all the options. And respecting people's choices regarding what they consider to be paths to recovery. It's important for you to know about those different pathways so that you can offer them to people and that you can also access them yourself. The second R is recognizes. So we recognize the signs and symptoms of trauma in family, clients, and staff. So we've talked in the beginning about how trauma might present, both in the immediate time following an event, and it could surface later. But we need to be educated and aware and being able to understand, okay, it sounds like this person possibly is having some difficulty with coping, or they're definitely having some difficulty with coping, and what they have been through so that we can provide the right response to those people. Which is the next one. The next R is response. So being trauma-informed care means that we respond in a way that fully integrates knowledge about trauma into our policies, procedures, and practices. In the Q&A, someone asked, well, what if my organization or the people around me aren't trauma-informed? Well, that's a situation that many of us are going to be facing, really. And so it's important for you to know that you can start making these changes just within yourself. And then maybe there's ways that you can take this training or take some of the information back to other people who might be open or interested. And there might be organizations who are really already doing some of these things or looking to go to the next level. So really looking at from all levels, from our receptionist to our CEO, what are we doing to make sure that we are responding to people in a trauma-informed care approach? And the last one is that we would resist inflicting re-traumatization. I'm going to go out on a limb and say that nobody here is intentionally going out and re-traumatizing people. However, we could do that accidentally, unintentionally, or potentially without even realizing it. And that can be a little bit daunting. But the more we're aware of trauma, the more we think about how we can implement these processes, then we decrease the likelihood of re-traumatizing someone. That system of care where people have systemic trauma from interacting, like Tony or Kane said, that she was traumatized through the system, we each play a role in creating a system that is able to heal trauma people have had and to prevent further traumatization through the way that we think and we talk and we do this work. And when we do the next section with the questions and answers, I would love if you guys want to throw in any ways that you're maybe already integrating this or think that you will moving forward. As kind of a summary, the key ingredients of trauma-informed clinical practices is that we involve clients in the treatment process. And I would kind of even broaden that and say that we involve everybody in the process, that if we're going to make policies and procedure changes, we need to understand for the frontline people what that's like for them and how they do their work so that we can make sure these changes are going to be appropriate. And we need to make sure with the clients that we're serving that we're involving them in the process. We're asking them questions, we're responding to their feedback, we're implementing that, we're respecting their preferences and needs. And we're not just saying it's my way or the highway. This is how we do it. And if you don't do it that way, then you're not ready or motivated. So really going back to asking, offering things in a variety of different ways so that people can be involved in accessing care in a way that's safe and functional for them. The other is also removing obstacles so that people can be able to access those services. So that might be language barriers, offering things in the home versus in the office, also being able to overcome physical obstacles like ADA and things like that. Some organizations have client feedback committees where they're able to then really have clients discuss what it's like to get services here so that we can directly respond to that and be able to make improvements as an organization. So screening for trauma, we've talked a lot about that, about what are the ways that we're going to make sure we understand a person's background. We could, if we're not going to do screening, keeping that understanding of trauma in our mind and letting that help us to understand the behavior as communication. But if we're going to do formal screening, then sort of like I mentioned before, we want to do it in a way that is supportive for the client and is going to benefit their treatment. We want to also make sure that people understand why they're being asked these questions. And it's essential that the person asking those questions, screening for trauma, is prepared to be able to respond to any reaction that the person may have. So if this triggers them or this causes them stress, or they want to understand why we need to know about, my 70-year-old client needs to understand why I need to know what happened in her childhood. So making sure that the people who are going to do that screening have the proper training and they have the tools to be able to make that beneficial for the client's care. Training staff in trauma-specific treatment approaches. So one of the key concepts with trauma-informed care is that within an organization, ideally, we would train everyone on trauma-informed care so that the receptionist and the CEO and everyone in between has some level of understanding about what trauma is, how that impacts a person, and how we can interact with people who have experienced trauma in a way that empowers them rather than re-traumatizing them. And that training that we provide to people might look different based on the different people's area of expertise. The front desk manager or the front desk receptionist is not going to need the same level of training as a therapist who's going into the home doing trauma-informed therapy. But they all need to understand the impact of trauma and how to be able to respond to it. So really working on training staff across all areas. And again, if your organization isn't really implementing this, you can start that process by taking this back and talking with your peers or your friends or family about trauma and the impact and ways that we can help support recovery so that people can go from being a victim to a survivor and ideally to a thriver. And the last is engaging referral source and partnering with organizations. So if you are in a professional capacity where you're working with trauma survivors, then you really want to know about all the different options that are out there. You might be a social worker who helps with housing. So, also you might want to know about the local food pantries. And this one is really kind and supportive to people, whereas this one's a little bit judgy. So I'm going to refer people over here. So not just knowing about referral sources, but also knowing which referral sources support people's recovery, that they're really creating that respect and support to people and working with them. Like Tony or Kane talked about so many different organizations and professionals that she interacted with that looked down on her, and she could feel that and the impact that had on her self-esteem and her ability to be able to make progress. So for us to make sure that we are within our role and ideally within our organization are supporting people's recovery and healing, but also that when we are collaborating with other people in the community, we're raising awareness about these practices and really able to connect with others who are going to be on board. I'll see if there's anything else I want to, also I would say on that, on number 4 with engaging referral sources, if you know that you have to refer someone to a system or organization that is not trauma informed, that it might be a challenge, and there's no other option, then I think it's important to be open and transparent with your client about that. We work with a lot of clients who are going through trial for sexual violence, child abuse. There's not a lot of ways to be able to make that system more trauma informed and supportive. It kind of is what it is. And there's things that we can do, but a part of what we can do is really supporting people who are going to have to access these systems that aren't as trauma informed or aren't as easy to be able to, as comfortable maybe is a better word. So really talking to my client about how to prepare for that and what to expect and the ways that they can get support as they're going through that. And that's a part of understanding and supporting people in a way that's trauma informed. We will talk with some organizations who are doing trauma informed care practices so that you can hear from some community partners about what it really looks like to put this into practice. And then we'll also respond to any Q&As.
Yes. So first we're going to do some Q&A. Thank you for a bunch of questions that are coming in. The first few are more questions from the first session that came in after the fact. So the first question being, when trauma happens from 18 to 25, does it still impact executive function and the brain the same way as it does from 0 to 17? Given all the frontal lobe doesn't form until 25, I'm guessing it could have some similar neurological effects. But then after 25, are there still brain changes?
Great question. And I'd like to preface my response with I am not a doctor or a neurologist. However, what we do know is that, the brain is developing into a person's early 20s. So adverse experiences in childhood certainly can have an impact on how the brain develops. However, as an adult, even if your brain is fully formed, you're in your 30s or whatnot, and you're experiencing traumatic events, that can certainly have an effect on the way that you think and are able to function. And what I would compare that to is to keep in mind that our brain is plastic. Our brain rewires, so to speak. Things that we don't use, we forget or we become less skilled at. So if a person is, as an adult, multiple times experiencing things that cause them to feel like I'm not safe or I have to be on edge, those neurons, those paths in your brain will become like super highways. And so a person will be more prone to interpret things from that perspective based on having multiple experiences in adulthood. The good news is that since our brain is plastic, that even as adults, we can work on rewiring some of that, but it definitely takes time.
Very good. Another brain question being, can PTSD symptoms develop 20 years after the event?
Yes. And I can give you a good example of a client I've worked with who experienced very severe trauma in childhood and moved away at, I think, 18 or 19, changed his name, really disconnected from all of that, lived a very happy, healthy, had a great career, raised a family, was very, very successful. In his late 40s, he happened to run into one of his abusers in the community, and he describes it was like being shot with a bullet. All of the physical feelings came back, all of the mental, the emotional, the memories, and full post-traumatic stress syndromes developed, and something that has been an ongoing issue of having to treat that. So symptoms can definitely manifest in the beginning or much later.
Very nice. So now moving on to some questions on working with individuals. So the first question is asking the member, the person you're talking to, what works or doesn't work for them after maybe continuous attempts or perceived lack of progress. Is that a legitimate question to ask them? For example, maybe after multiple no-shows?
For me, it would be yes. That's a definite yes. And taking that trauma-informed care approach is that we're not going to judge people. We're going to look at what's going on that's making it difficult for you to be able to access these services. So I would continually be asking that question, but asking it from the point of saying, you keep scheduling more appointments. I know you want to get some support and services. Let's talk about a way that we can find what's going to work for you. And looking at how I'm providing the services, is there something I'm doing that's maybe making it difficult for this person to be able to come? Is there a different way that we can connect them? Maybe they need a different day of the week, or they need community-based, or the things that I'm trying to do aren't where they're at. So I definitely think that is absolutely important thing that we have to continue to do with everyone. Meet them where they're at and figure out how to support them from there.
Very nice. So the next couple questions, we have some thumbs up on them. So multiple people are wanting to ask these questions. Do you have any recommendations on how to get clients to open up if they've had a bad experience with you as an organization or a partner? I mean, it's hard to correct things that are harmful if you don't know about them, but many clients also don't want to complain.
Definitely. And I would suggest seeking that feedback in multiple formats. So you might have a suggestion box, you might have, a place on your website. You could also, as a professional, be opening up that conversation and just really creating the space where you want to know. And I often tell people, part of my job as a manager, I follow up with client concerns and I don't want to get anybody in trouble. This is not about getting anyone in trouble. This is about us being able to provide the best quality service. And if you've had an experience that was uncomfortable, then there might be other people who are going through that too, who aren't able to speak up about it. And so we really want to know this so that we can provide the best possible care. And then to do something with that information to make sure that we are creating a better environment.
Very nice. So the next question is, would you suggest any other strategies for supporting clients who have experienced complex trauma but are still stuck in a system that's constantly re-traumatizing them?
Sure. It's definitely a challenge. So I would, be looking at how maybe implementing these processes, other referrals or community partners who can support recovery, and also community resources and validating, normalizing that if a person has had a lot of challenges, their community might have challenges, they've had multiple traumatic events, of really expecting and normalizing that they probably will need ongoing support, and letting yourself be a place that is a healing experience for them.
Very nice. The next question is, the depth of the juvenile justice has trauma-informed care built into the trainings and curriculum, and it's a major part of the care and service systems. What we don't think about sometimes is that the children are now adults and need the same kind of care. So how do we build it in now and going forward?
That's a great point. And I don't mean to imply that any of these systems don't try to be trauma informed or that they intend to traumatize people, because I know that's not anyone's intention. So I think that this is definitely an area that we need advocacy and education, and that shift in perspective of seeing people as having bad behavior versus having had experiences that are difficult to cope with and that are impacting their ongoing behavior would be a way that we could help the adult judicial system, have a different perspective and help people. So.
Very nice. And a somewhat similar question that was in the chat, but it wasn't in the Q&A, that I'll also throw your way, is what are some good resources for individuals released from the correctional institutions that are having a rough time adapting to what's called the new normal?
Sure. Well, working with people being recently released is not my area of expertise, but I do know that PERC is a community partner that does a lot to support people who are reintegrating. Not to plug my own agency, but we have a forensic program that works with people who are recently released to help them with case management and therapy, all of those things. So I would really think about all the different needs that person might be having, and knowing that it's probably not just one agency that's going to do it all, but knowing the different resources in the area who are supportive and see people as wanting a better life and doing things to try and help them have that.
Very nice. So the next question is, I don't know if it's directed towards you or to the group, or what the sort of the next part of this question would be, but it starts with, has anyone ever worked closely with an individual who was conceived from a sexual traumatic event?
That's interesting. I have not personally had that experience of working with a child or an adult who was conceived during a rape. But I've been on the other side of working with women who are pregnant. And so I would think that linking them with a social worker or a therapist who has some expertise in dealing with trauma and sexual assault to be able to support that person in addressing any concerns or feelings they have about that.
Very nice. And then lastly, just could you please repeat the author you mentioned on systemic traumatization or re-traumatization?
The person I spoke of about that is Tonier Kane, Tonier, and last name Cain. Another resource if you're interested in knowing about how trauma affects the brain, especially even as an adult, is The Body Keeps the Score, which is a really good book that has a ton of information. It's sometimes in too much depth about the medical and brain and all of that, but it really gives a perspective of the impact that trauma can have over a person's life.
Put that book, The Body Keeps the Score, in the chat. Can you repeat also the author so I can put that in the chat as well?
It's Van der Kolk.
Spell that for me.
I think it's VONDERKOLK, I believe. And Tonier Kane is TONIERCAIN, and she has tons of information, a website on ways to be an advocate for creating more trauma-informed care for people and improving the various systems that individuals are accessing.
Those are all the questions. Thank you all for asking these questions. Keep them coming. And now, as Carolyn mentioned, we'll move on to the home stretch.
Okay, yeah, these are great questions. So we'll talk a little bit now about 3 different organizations here in the Tampa Bay area that are using some trauma-informed processes and procedures. So that we've talked about the concept, so let's see now how it can actually be applied in our work. So first, I just want to highlight this quote from Dr. Machtinger, if I say that right. It's very difficult for most providers and clinics to help patients heal from lifelong trauma and prevent re-victimization on their own. Forming partnerships with community-based organizations is essential. So we all play a role in helping to prevent system-induced trauma. And it's really helpful and imperative even to have a community-based approach so that we know other areas that can really help to wrap around a person. And also so that they have options, that if what I know isn't a good fit for them, that there's other places or other people who can also help. So Suncoast Center is where I work, and I'll talk a little bit about some of our trauma-informed practices. So trauma-informed care is something that's really important to us. That's why I'm here doing this presentation, and it's something that we really try to integrate in our work on all levels. So some of the things that we do, well, and if you're not familiar with our organization, we are a community nonprofit mental health and substance abuse provider. We have counseling, case management, psychiatric services, programs that work from pregnant mothers expecting to all the way across the lifespan. We treat everything from a mild adjustment to the most severe and persistent mental illness. With the FACT team, or people being discharged from the state hospital. So we kind of touch all different parts of the community, and definitely see many, many people who have experienced trauma in their life. And many of the people who are accessing services, they're not necessarily coming in saying, I want services because I was abused when I was a kid. They're coming in because they're having relationship problems, or they're depressed, or they're having substance use issues. And that's all a part of these adverse childhood experiences or trauma that may occur across a person's lifespan. Some of the ways that we try to respond and support individuals who we both work with as staff and also who we work with as clients is that we screen everyone at intake for depression, suicidal ideation, and trauma. So at the first contact, the call intake, we will screen for trauma, and based on that, We will determine which direction they need to go in as far as seeing a specialist or seeing someone who is more of a general practitioner. When they have their first contact with the intake person, then we do a PHQ-9, which is the patient health questionnaire. It's 9 questions, and a person indicates how many depressive symptoms they've had, if they've had any suicidal ideations. And then based on that, we're able to further triage of, do they have trauma? Do they have depression? Do they have suicidal ideation? How do we need to navigate this person? We also, if there's multiple programs that would be a fit for what their history and presenting concerns are, is we'll tell them, hey, you would be, total family strategies, outpatient, these are options. What would be your preference? And then we will try to funnel them in that direction. When the person meets with a therapist for the first intake, that's when we do a more in-depth assessment where we would go through their history, do more education about trauma, symptoms of mental health or substance abuse, and be able to kind of figure out further what exactly their concerns are and how we should address that. So our screening occurs on the front end by multiple different people, but each person is doing something different. So we're not repeatedly asking person the same questions and then not really providing any explanation about why we need that or how we're going to use that. It's not until they get in front of a therapist for that in-depth intake that we would really go into a more thorough assessment and education about trauma or suicide and how we can address it. So like I said, we provide services in a variety of formats. We have programs that are office-based. We have programs where case managers or therapists come out to a person's home. We have programs where case managers or therapists go into the jail, they go into the state hospital. So we meet people in all different parts of the community based on what they need. And that's really important. To be able to help remove barriers and make it safe for everyone to be able to get services. We also offer services in not only a variety of locations, but also in a variety of formats. So we have telehealth like this, where we can conduct case management, psychiatric, counseling services via telehealth. We also provide some phone-based services where we are able to provide therapy or support groups or different things like that over the phone, as opposed to having to be face-to-face. Not everyone has internet access and can, utilize telehealth. And then, of course, we have office-based services. So some of our clients might have transportation barriers. We have ways to be able to help them overcome that. So we really try to make it comfortable for people to be able to get the help that they want and need. We also have policies and procedures for responding to a person in crisis. And these interventions emphasize we have a hard, no physical contact, no restraint policy. No one is ever allowed to put their hands on someone else, even if they're in crisis. And that's important because you can't look at somebody and know whether they have a trauma history. I might know with my best friend, if I put my hand on her shoulder when she's upset, that'll help her to kind of calm down and regroup. If somebody in the lobby is screaming and I walk up and touch their shoulder, that might really trigger them into where they then become physically aggressive or they become more upset because of that contact, which was in no way intended to be able to create further escalation. So we use that no contact policy for staff and client interventions. And we really focus on psychological interventions. So all of our staff, every role in the agency, if you have any contact with clients, whether that's over the phone or in face-to-face or in the community, they go through an in-depth training with me on psychological interventions to help with decreasing, to help with being able to recognize signs of escalation earlier, and then being able to respond across the spectrum from when somebody is mildly agitated to when somebody is in crisis and dangerous. So that really helps to have everybody on board with the same things and knowing how to respond when there's a crisis situation. We also have some practices regarding follow-up after that. We do a debriefing with people. We will follow up multiple times over a period to be able to check, because the day of, someone may be like, I'm okay. And 2 weeks later, they might be having difficulty sleeping or feeling scared about coming to work because of the situation that happened. And so it's really important over time that we continue to check in with that person. We also have different people, because someone may be comfortable talking to HR, but they're not comfortable talking to their supervisor or whatnot. So making sure that we're offering that support and being able to respond. We review every incident and have a committee who does that. And I mean every incident, from a crisis to somebody tripped and fell, and really look at what are our, how did this happen? How do we respond to it? And how do we prevent something like this from happening again in the future, so that if there are any, potentially traumatic events for staff or clients, that we are addressing that and also preventing recurrence when possible. We utilize multiple formats to highlight client and staff successes. So that's a part of the strengths-based approach of trauma-informed care. So we do an annual success breakfast where staff or clients, they nominate people who have made progress, who have had some success. And it doesn't have to mean that they're cured, but maybe they've come over a big hump and they're like really doing better in some ways. And so it's a community event where community partners, people who are interested in knowing about services, staff, clients, anybody can come, and we really highlight those successes, normalize that people are going to experience challenges, whether it's a serious, life or death situation, to just day-to-day stressors of, raising a family and work-life balance, and how treatment can work and help people. We also use success stories as a part of our, I don't know if marketing is the right word, but getting the word out there. So we encourage clients to share with us. We have comments that they can put in, staff send them in, highlighting ways that people have progressed. We also have an active social media to try and raise awareness about mental health services, about coping with stress, and trying to encourage people to be able to access services, whether it's with us or one of our great community partners. And then we also have what we call Coastlines, which is an internal magazine, I guess, for the agency. And every month that comes out. And a part of that is that we recognize staff. So anyone within the agency has the ability to nominate someone who they see going above and beyond. And that could be anything from, you responded really quickly and helped that person who was in crisis, to something really huge, like somebody got their licensure or all different things. But anyone can make nominations, and then those are posted for agency-wide, everyone to review, really highlighting ways that peers see others going above and beyond. And that makes a difference. People feel good about that. We also do celebrations where we really highlight somebody who, one-on-one or within like a big staff meeting, of really recognizing people who are making a difference and building on those strengths within our organization. And feeling good about the work you do translates out into the work you do with people, of feeling good about that too. Suncoast Center provides crisis intervention training for local law enforcement. So law enforcement comes and spends usually 2 days with our organization and also with some partners, and we provide in-depth training on understanding the impact of trauma, whether that was in childhood or as an adult, understanding mental health presentations, and providing training for law enforcement to be able to respond out in the community with a trauma-informed approach. And that can make a huge difference. So really helping to raise awareness in the community. And the last one says emphasizing mental wellness over mental illness. And that's important. It's one of our taglines. One of our priorities is really removing the stigma related to mental health and encouraging people and really raising awareness that dealing with emotional or mental health challenges is no different than dealing with some of the physical health issues that we have from time to time, or that might be a regular part of our life. And so really helping people to know that, wanting or needing help doesn't mean that you're inadequate or that something's wrong with you. That is perfectly okay. And it's an integral part. Your mental health, your emotional health is an integral part of your overall well-being. So there's lots of other ways that we as an organization work to be trauma informed, to offer options, to empower clients, to recognize progress and to create or recognize successes. And to really create an environment that's safe and supportive for everyone. But that's a little bit of background. And so now I'm going to turn it over to Ricardo, and he's going to introduce some of our community partners who are also going to talk about their organization and what they do to be trauma informed.
Thank you, Carolyn. I'm Ricardo Enriquez. I'm with United Way Suncoast, and we invited two other partners to share their experience implementing trauma-informed care in their practices. A big part of this training is to share with you, as we have said, that we can, as professionals, we can take some steps on providing more trauma-informed services, and as organizations, we can do the same. So first, I want to introduce Angela Carpenter. Angela is a program supervisor at Personal Enrichment Through Mental Health Services, also known as PEMS. Angela, thank you for joining us.
Hi, everyone. This is Angela Carpenter, and we are funded through the Juvenile Welfare Board, and we provide preventative case management services to Pinellas County families that have minor children in their home. Our primary referrals come from 211 and are assigned to a system navigator. Our other referral sources come from Pinellas County School Board social workers located within 7 different transformational zone schools and the Sheriff's Department. All of our staff are trained in trauma-informed care and have been using it for many years now, along with mental health first aid, assist suicide prevention, stages of change, and motivational interviewing. Many of our trainings are easily, Many of our trainings are easily accessible and offered through our organization, JWB, Suncoast, and programs through St. Petersburg College, NOVA, and SAMHSA, who also offer training materials on their website. And they provide booklets and other materials and tools that staff can utilize easily with families. When the staff complete their intake assessment, they utilize the training to listen for potential areas of concern. And throughout the life of the case, cases are reviewed with supervisors by the staff so that anything in particular that sticks out can be assisted and addressed immediately. The impact of the trauma-informed care training has helped our staff gain awareness of life situations that could cause trauma in children and their caregivers. It also helps them identify and talk with families about behaviors that may occur as a result of trauma exposure. By using trauma-informed care, the staff feel more knowledgeable to educate families and make recommendations for longer-term linkage, use self-care, and reduce burnout and compassion fatigue, which you heard Carolyn talk about a little bit during her presentation. And I really didn't have too much more prepared just because I wasn't sure how much time we would have. So I'm not sure if anybody has any questions. Hello?
Angela, thank you for sharing your experience with PEMS. I think that what we can do is if anybody have any questions, please put them on our Q&A. And then at the end of the presentation, we will go back to those questions and you will have the opportunity to answer. Does that work?
Okay, that sounds wonderful. Thank you.
Thank you so much, Angela, for sharing with us. And now I want to introduce Dr. Myra McPherson from Girls Inc. Dr. McPherson is a certified trauma professional, and she will be sharing some of the practices of her organization. Dr. McPherson?
Okay, hang on. There we go. Okay. Hello, everybody. I am Myra McPherson, and yes, I'm at Girls Inc., and I've been asked just to talk a little bit about the trauma-informed program that we have under our wonderful Baranczyk-funded special program called the Family Strengthening Program. Let me briefly tell you what it's all about. It started about 4 years ago, thinking that there are the girls that come for the after-school program that needed a little bit of extra support and possibly case management and counseling as well. My personal love is parenting, and that if you help the family, you're really helping the child. And this is a program, in case you do not know, it's a program for after-school program to help a girl become all they can possibly be, which the logo is Strong, Smart, and Bold, which encompasses curriculum from the National Girls Inc. Incorporated. And when it was first introduced that perhaps we should do some trauma-informed work, it was very apparent to me that the girls were coming off the bus with just so many very serious situations that it was more than what I personally could see. We have another therapist there as well who just comes on campus twice a week so that we can just take the most serious girls. And otherwise we do multiple times per week get in touch with a case manager who sees the girls every single day so that they always have somebody that they can talk to. I love helping the parents. For example, when out in the hallway, you see so much when they come to pick the little girl up or their daughter up. And the parent said to me just last week, all she wants is my attention. She's driving me crazy. I said, she does want your attention. She's going to do anything she can to get that attention. So I offered not to judge her, but rather to give her some support so that she'd understand why her daughter is acting the way she's acting. When we first started implementing this, I think that the executive staff was a little nervous how staff would respond. And actually, they responded beautifully. What I simply did, I did the training for them and just said, do what you're doing because you are probably the one protective factor in this little girl's life. Believe in their goodness. And instead of occasionally a child would act out in a negative way, instead of the mindset of, what is wrong with this girl? It's rather what's happened to this girl. And that was probably the biggest change that we went through. Otherwise, I've done a couple of several trainings just for questions and answers or additional resources to offer them as staff. And everything is just very age appropriate based, depending on their social and emotional development. And the staff has just been so open to more trainings and asking questions. The one thing I have missed tremendously as part of the Family Strengthening Program was that we always had done monthly and sometimes bi-monthly parenting nights where the parents would be fed by our Girls Inc. staff, and they would have the whole evening to talk about what issues they're having at home. And I think that was extremely helpful to their mental health to realize that they're not alone with whatever developmental problem they're having. And we haven't been able to do that as much, obviously not in a group because of COVID. So this summer, what we did, I thought Girls Inc. was awesome. They provided food for the families. We all continued up with the families that we were currently serving, letting them know we were here for you. All you had to do is let us know. Food would be distributed twice a week. And I ran out there a couple of times. I got a real kick out of it. I called it drive-by counseling. So the people would roll their window down. I'd say, so how's it going? And they would let me know what particular issue they were having. I'd suggest a couple of techniques to try, etc. I actually found that fun. The new thing that we're doing this next school year, because we have found such a huge need for mental health support, especially because this has been a difficult school year and the children have been home a lot and sitting a lot, is we have suggested that there's more movement activity and more mindfulness and calming of the physical body of these girls, because they have no way of getting this out. They have to sit for long, long periods of time. And we're implementing what's a program is called Inner Explorer, which is a child of any age can check in every single day to see how they're doing as far as their stress level, to where they can be taught by the use of a laptop how to calm their bodies down. All right, let me tell you the new things that are happening this school year. I'm doing groups with the high school girls. I believe in prevention before they leave their parents' home, and I love prevention and when they first come to Girls Inc. when they're 5 and 6. I think both times they really need some help. I'm enjoying doing a relationship group where I talk about what is not a healthy relationship, an intimate relationship. Of course, teenagers just love talking about their relationships. And so today we're talking about what is a healthy relationship. They know what an unhealthy relationship is, but they have no clue if they've never seen it, or if their parents admit that they would like to be in the class, because every single one of us, there's no such thing as a person that is not workable. It's just most of us need more tools in our toolboxes for having healthy relationships, not only personally, but with their daughter. So this afternoon, we're doing role plays on how to have a healthy relationship. And I'm looking forward to that, because we all want to be loved, regardless of how old or young we are. Then we're also doing some SIESIS groups, which is the teen parent program in town over at Riverview. We just started that group, same thing on relationships and also how it affects their child. My area of expertise is really the first 3 years of life, infant mental health. And I relate that to that the foundation is right now being set for their child. And if they have been traumatized, and many girls have no clue that they've been traumatized. So I've taken the ACEs test and just kind of made it into a less wordy for what I consider I can use quickly. And I just asked them for how many yeses they had. And that tells me everything I need to know. They don't need to tell me anything more about them, because no one wants their story told in a group, usually as a teenager. Then we have 2 staff people that are going into schools to help pick up the slack from, there's a lot of children that need a lot of help, and families as well. And I understand, I only interact with those ladies a couple of times a month, but I understand from yesterday that is going very, very well. And I'm thrilled about that. So let's see, what else do we have? When we are not a counseling program, I want to make that clear. Although when girls present with either some grief or some loss or some behavioral issues, we do what we can to give them support. And if it's a very serious issue, we may give them out to one of the community partners so that you can do more in-depth work, but always include the family in everything that we're doing. And asking them, of course, I always let them know we're not here to judge you. We're here to support you in any way we can. So with that said, I got to be mindful that I don't talk too much. I'm happy to say that Girls Inc. National has just awarded Girls Inc. locally with an award for this family strengthening program, because I do strongly believe that we live what we've learned and we give what we've got. So in order to break the cycle, which usually takes several generations, I'm into the power of now and what we can do to support and believe in girls when they have lost belief in themselves. So that's the basic philosophy. So I'm happy to answer any questions for those of you who are not familiar with Girls Inc. And I think I'm going to hold it at that, unless anybody has any questions for me.
Thank you, Dr. McPherson. Thank you for sharing the experience and the work that Girls Inc. is doing. Like I said before, please, if you have any questions, add them to the Q&A. If it is specifically for one of our partner presenters, please include their name so they can answer for you. And now I'm going to go back to Caroline, who will be talking about resiliency. Thank you.
Thank you both, Angela and Dr. McPherson, for the information on your programs. It's interesting to see from sort of the crisis with PEMS to more of addressing and prevention, and really working with a whole family system with Girls Inc. And then with Suncoast, just a variety of different ways to reach out. And so it's really exciting to hear about that. And I would also encourage you all to remember there are over 200 people here on this training today. And these are all allies who are interested in learning more about trauma-informed care and being able to make this a part of our practice. So whether you're a beginner and this is your first time hearing about this, or you're someone who's really practicing it, there's lots of people who we can use as resources for developing our skills and having good community partners. So thank you all for being here. So now we're going to talk about resilience. So we've talked a lot about the impact of trauma, all of the ways it can harm someone, and how to practice carefully and in a trauma-informed way. And so I want to bring it to a close with some talks about resilience. And resilience is really something that maybe we don't focus on so much. And it's really easy if we're a service provider and we're seeing what's the problem and we're seeing people in distress, that we would be focused on that. But we also want to keep that bigger picture and utilize a strength-based approach. And resilience is a big part of that. So here we're going to watch a video from Dr. Hone. And Dr. Hone was a researcher, or is a researcher, on resilience. And she'll talk in this video about how, as an adult, she experienced a very traumatic event, the impact that had on her, and also what helped her to be more resilient, and how she has learned to share that information with the broader population so that we can all work to develop resilience in ourselves and others.
You just feel like you are climbing a mountain every day, and every day you get up and the same mountain is ahead of you. My wee girl Abby, who was 12 at the time, hopped in the car with her best friend Ella, and Ella's mum, who was also a really dear friend of mine. And on the way down, a driver sped straight through a stop sign, crashed into them, and killed all three of them. So I just have this peculiar insight, really, that, I've done the academic study, I've trawled over all of the research, and then I've had to really test what works in a really, obviously, horrifically personal way. And I can say that I feel really lucky now, because having had that training, I did at least have some tools at my fingertips. But I want to make a really important point here, that too often people focus on resilience thinking it's just a personal thing. And actually we know that it's much, much bigger than that. Not seeing yourself represented in society is potentially damaging for your resilience, whether it's race, sexuality, ability, mental illness, any form of prejudice like that feeling that you don't belong, you're not seen and you're not heard, is hurtful and reductive when it comes to resilience. So why is it important for a country to be resilient? Because it enables us to mobilize our resources faster. And in that, I mean everything from portaloos to trust. Think about our ever-changing environments that we know we all live in nowadays. Bushfires, COVID, the earthquakes, change and adversity come thick and fast, and resilient societies, resilient nations are so much better able to respond in that time, to be able to protect their weak, their vulnerable, to be able to protect the economy, to weather whatever comes in a much better way. So on that personal perspective, the good news is that research shows that resilience really requires what we call ordinary magic. It's not some elusive trait that is only available to a few. We can teach people to be more resilient. The three strategies that I relied on when the girls died, and to be fair, I absolutely still rely on now, I've wheeled them all out again recently, are the number one is understand that suffering is part of life, whether it is divorce or redundancy, losing a partner. Really, tough things happen to us all. So knowing that, going into this terrible experience, knowing that adversity was common and that suffering was common, really did make a difference because it prevented me from feeling singled out. Number two, tune into the good. We get sucked into what we call in psychology a negativity bias. You know, we're really good humans at looking at all the crappy bits, but actually we're not so good at tuning into the good stuff. And it's really, really important for us to counterbalance that by choosing to focus our attention on some of the good stuff. And resilient people are really careful to choose where they focus their attention. Number three, ask yourself, is this helping or harming me? Is the way I'm thinking, is the way I'm acting right now helping or harming me in my quest to get through this? All too often, people think that resilience is about that good old stiff upper lip, and it's not that at all. Actually, being resilient is also being able to accept your vulnerabilities, knowing when you need to get help and to reach out. Studies have shown that having strong supportive relationships is probably the most important thing we can do to build resilience. We were really lucky. We had a really supportive community who helped us. And all of this is what you need when you navigate trauma and adversity. Nobody goes it alone. And one of the key researchers in the field, Chris Peterson, used to say, other people matter. That was the 3-word summary of his decades of research.
I think Dr. Hohn's story is a powerful one, and something that always stands out to me is that other people matter. That having others who care about you, who see you, who are there for you, that can make a tremendous difference. And for some of the people we work with, you smiling and saying, "I'm so glad that you're here," is you are that other person who matters for them. And so being able to see that we can all help to develop resilience, and that it's not something that's hard and fast, that even showing up for services is somebody reaching out, being resilient, asking for help. And so we'll talk a little bit more about some of the myths and facts of resilience next. So this is kind of a breakdown of some of the myths and some of the facts. I'm going to focus on more of the facts, which is an ability to regulate emotions. So, you know, being able to be emotional, to be able to express and be vulnerable, but not to be overwhelmed by that. And so we might be teaching people ways to be able to regulate their emotions, or linking them to other people who can help them to learn those skills. And by doing that, we're helping them to become more resilient. Resilient people tend to have relationships, or there was a time when maybe they were. And so really focusing on not just the individual and what is their presenting problem, but what is their community? What are their supports? That might be you, and there might be other people. So really helping them to be able to see or create and access supportive relationships can help to foster resilience. Seeing that asking for help is a strategy for being resilient, of not having that stiff upper lip, like she said, of that I just have to get through it, and no matter what the cost is, I'm going to go it alone. So really normalizing people coming in for services, whatever that might look like, or for yourself. And also knowing that people might need care over a period of time. And, you know, there might be people who have one small thing, but a lot of people have complex challenges and they're going to need ongoing support. So really encouraging that and seeing it as a way that they are stronger. So know when to slow down. I think that's important, is that kind of being able to if we're with someone else, read how they're doing and being able to adjust. And for ourselves, also being able to check in and know sort of when I need to slow down and do a little less or take care of things and get help and things like that. Resilience is not always pretty. I think that's a good one, that resilient people aren't perfect. They don't always have it together. That we're all still human, but even that person who you might be talking to or working with who's really sort of a mess, that also being able to see, wow, there's also things about this person that are strengths and that are resilient, and being able to build on that. Everyone can develop resilience. Sometimes it seems when I hear people talking as though resilience is like an inborn trait. You're resilient or you're not, but that's a myth. We can definitely learn about resilience, teach people about resilience, and help them to become more resilient. I said that when I do the adverse childhood scale, I also always do the resilience scale. And even if a person's score is 0 on the resilience, which I have never had happen, then I can use that as a tool to say, well, this is good information, and let's figure out some of the different areas, maybe where you want to start to be able to focus to build that resilience. And rejuvenation fuels resilience. So being able to have a sense of accomplishment, to be able to overcome things, these are a part of being able to feel like you are resilient. And resilient really means that you can, or a person faces a hardship, they face a challenge, and they're able to bounce back or move forward, and they're better for having had faced that hardship. This is a little diagram, I guess, that I found from Ivan Staroversky. I apologize, Ivan, I butchered your name, but he is a psychologist and researcher, and he did some studies on how resiliency impacts people who are dealing with depression and anxiety. Really interesting stuff. He has tons of things out there on the internet, on Twitter, Instagram, YouTube. So if you're interested, you can read up on him. But he identifies here some of the different areas that a person could be resilient in. And there's some that he has that have even more branches, but it was just too big. So really thinking about coping with stress effectively in a healthy manner, that's that sort of mental fitness of being able to ask yourself, is this helpful what I'm doing? And to maybe do something different, or to reach out for help so that you can learn different ways. Problem solving skills, having the ability to be able to access services, being okay with accessing services, having a belief in one's ability to manage feelings, to cope, to overcome hardships. And sometimes when we're working with people, they may not have that belief when they start services, but we can believe for them that they have strength and that they can be resilient and come out on the other side of these things. And in that, it helps them to be able to develop that belief also. Seeing themselves as a survivor rather than a victim, and that can take time, or even moving from a victim to a thriver. Having some supports, whether that's a professional, spirituality, a peer, a pet, having some kind of support system. Seeing how they can help others is a really big part of resilience. So whether that's using their experience to be able to be a better parent or be a better friend, or even going to the link that Tony Kane did, where she has become a very well-known and respected advocate in the field for helping trauma survivors to have better access to services and to educate providers. Finding some positive meaning in trauma. This is sometimes referred to as post-traumatic growth, and it's really sort of the definition of resilience, of being able to get to the place where a person feels like, having faced this traumatic event, I am stronger, I am more capable than I realized before that. self-disclosure of trauma to loved ones or to someone, of having someone that they're able to talk through, to process these events, and to be heard and respected and supported. Spirituality, and then some connection with family or friends, or I would even go broader than that. So it kind of puts together how there's lots of different ways to be able to be resilient or to help people to develop that. So next we'll talk a little bit about some tools for developing resilience. So one of them is self-care, and I would define self-care as all of the things that we do that help us to feel relaxed or help us to feel energized. The things that help me with self-care might be different than what Dr. Pearson finds as rejuvenating or relaxing. So it's really, you need to know yourself and know what is it that I need in order to have good self-care. The other part of that is short-term and long-term needs. So what am I doing in the short term, day to day, to be able to support my self-care? And then over the long term, so long term could be things like getting routine medical care, taking vacations, maybe my personal growth or my development in different areas is a part of how I'm nourishing myself. It looks different for everyone, but we have to understand what it is so that we can prioritize it. And one thing I always say with the people I work with is that self-care can't just happen on the weekends. Sometimes as professionals, oh, I'm going to go to yoga on Sunday, or I like to go out bowling on the weekend. But then Monday through Friday, you're just plowing through your work and feeling completely exhausted and depleted by the end of that. That's a recipe for compassion fatigue or burnout. We really have to prioritize doing things throughout the day, every day, that are self-care. And that could be something small, like taking your lunch break away from your computer, or calling someone and chatting, or going for a walk. And it could be something bigger. And as organizations, we really have to work to communicate that self-care is important for our staff and to allow opportunities for people to be able to make use of their self-care as a part of their work-life balance. So it really needs to go in all directions of us owning that, and then also really communicating from the bottom up and the top down within our organizations about why this is important. Which is sort of the next point of developing that culture that recognizes the impact of trauma and the power of resiliency. So it's not just about our clients, it's also about us as people and professionals. And looking out into the communities that we serve, what are their strengths? What are their areas of resilience? How can we build on that and make use of it, or even help it to grow so that there's more strength there? It's important for us to understand resources, both our internal and external resources. Our internal resources are things like our coping skills, self-talk, meditation, mindfulness, being able to let go of things when you ask yourself, is this helpful for me? And you say no, to then be able to move on. And our external resources are the things like our support system, our training, our environment in our workplace, our peers, everyone around us, our financial resources, all of those things are external. So really kind of taking stock of what are my internal resources, what are my external resources, whether I'm talking about myself or person who I'm serving, and being able to really make use of those. And if there's areas that are a deficit, of how do we address that? What are some options, and how do I make this stronger? Because that's what it's really about. And last is, what do I have control over? So people don't have control over the traumatic events that happen to them, but we do have the ability to be able to make meaning in that and to move forward in a way that's healthy and happy and healing. And so sometimes really making sure that we're picking our battles. And like it said in the video, that resilient people are careful about where they put their attention and their energy. We are primed through evolution to pay attention to things that are dangerous, scary, and to really remember that. And we have to work a lot harder to be able to focus on and retain the things that help us maybe to feel happy or safe. And that's only amplified in a person who's experienced trauma. So really making some intentional efforts to be able to look at what are my strengths, what is this other person's strength, where is resilience, where are things that I can help to move forward. Makes me think kind of the Serenity Prayer, if you're familiar with that. It's always a good one. So next is compassion satisfaction, and compassion satisfaction is defined as the positive feelings that someone derives from competent performance, engagement with colleagues, and a conviction that one's work makes a meaningful contribution. That's a really powerful statement. There's a lot of important stuff in there. So it's really a feeling of satisfaction that comes from when we are able to perform competently. We feel like we have the tools to be able to do our job and support the work that we want to do. And so that's an important part of being trained up, as it said earlier. Tony Arcane said that, so that we can be competent. And also looking at, sometimes we don't get to see the positive outcomes. We're planting the seed and then the person is moving on their journey. So really looking at maybe for ourselves or making sure that as organizations, we're recognizing the way that people are competent. The engagement with colleagues. So our environment is really important. We've probably all been in a toxic workplace and we know what that's like. But as a person or as part of an organization, really creating an environment that fosters this compassion satisfaction, that's strengths-based, that is able to say that, you know, the support I get from these people helps build me up and helps me to be better. And a conviction that one's work makes a meaningful contribution. And so being able to see or to feel like you are doing something that makes a difference in the world. And that's why we all came into this field, is in some capacity, we wanted to make that difference. We wanted to have a meaningful contribution in the world. And so making the intent to be able to recognize that in when you have those accomplishments or when other people do. When I was in grad school, my mentor gave me a shoebox and said, anytime you get like a note or somebody sends you an email that says, wow, you really made a difference, put it in your shoebox. And then when that day comes, when you feel like, it's pointless, nothing matters, I can't do this, it makes no difference, take out your shoebox and remember these different small or big things that you've accomplished over the years that have made a difference in people's life. And I didn't think I would need that, but I did it. And I still have that shoebox. It's over there on my bookshelf. And there have been multiple times when I took it out and I have read through those little things. And it does make a difference to be able to shift and to remember that maybe not every day we're having a breakthrough, but even just being there, being that compassionate witness, respecting people, trying to help people to become empowered, that can help us to create these feelings of compassion satisfaction. And it's really sort of the positive effects that we as professionals, or even in our personal life, that by witnessing another person's recovery from trauma or adversity, that it increases our own hopefulness and our own capacity to emotionally engage with others. So compassion satisfaction is the antidote to compassion fatigue and burnout. So it's really, really important that we prioritize these things and work together with our partners to help support having a really happy, healthy workforce. So last is just kind of a very general overview of trauma-informed care. This is my call to action for all of you who have attended part or all of this training. This is a lot of information, and I really am happy that you're all here. But I really hope that everybody will leave here today feeling energized in some way and feeling motivated to take this information back and to put some of it into practice. And trauma-informed care looks different in every place that it's practiced because all of our roles are different, our organizations are different, and our communities are different. but we can each make a difference in how we serve people by being more trauma informed. So keep the conversation going. Everyone in this room is an ally, and I know that you're going to take this out into the world and help others to become allies also. So maybe think about what are some ways that you can integrate culturally responsive principles, service recipient involvement, and workforce development to help really continue the growth of trauma-informed care in our for our community. So that is everything that I have. That's my contact information if you want to reach out, if you have additional thoughts. And I really appreciate everybody being here. I really enjoyed this. It's a joy to be able to see so many people motivated about learning about this topic. So I am going to turn it back over to Doug so that he can take us through the last bit.
Yes, and so we are just about done. This is the last opportunity for questions. And so once we finish with questions, we'll thank you all. So before I do go to questions, I want to send a huge thank you to Carolyn for just being a hero of heroes, presenting this information. It's great content. I love the shoebox idea. I'm going to do it. Again, a huge thank you to PEMS and to Girls Inc. for sharing your stories as well. We do have a few questions. Angela and Dr. McPherson, if you're still available. We have some questions in the Q&A specifically for you all. Dr. McPherson, I believe we have one for you about your Girls Inc. programs available to trans girls as well. And Angela, I don't know if you have any programs that you'd want to answer to that. But either Dr. McPherson or Angela, are you available to answer any of those questions?
Yes, I'll just jump in real quick. We work with any population that we come across, and we use interpreters for deaf and hard of hearing, as well as language issues. So we're not fearful of any of those additional issues that we might come across, and we're willing to work with anyone.
I'm here as well. This is Myra McPherson.
Yes, I hear you.
Yes, we are available to work with definitely trans, no problem there. We've had it occur several times, as well as I actually used to teach deaf and hard of hearing students in Sarasota County. So we've had a few hard of hearing people in there, and the girls loved learning sign language. So yes, we will. There's no one we will turn away.
And then I think the next one's a question for all three of you. How can a case manager refer a client to any of your programs? They're asking specifically if you have an office located in Hillsborough County. I know you all are Pinellas and Sarasota just for these examples. But how can a case manager refer a client to either or any of your three programs?
Shall I speak? Okay. This is Myra again.
Yep.
It would be a girl 5 to 18. And my guess is you can call the local Girls Inc. Telephone number, which I can give to you, is 941-366-6646. And that's the general number, and the receptionist will forward the call on to whoever would be the appropriate person to answer that.
Carolyn, next, and then Angela.
Suncoast Center, the main number is up there, the 727-388-1220. Anyone who is interested in services, who is not currently a client, can go on call that number and be able to set up services. In Hillsborough, we only serve Pinellas County, but I would also say that anybody who's outside of Pinellas County you can always link people to 211. You just call 211 on the phone. Tell them where you are and what it is that you're needing, whether that's a food pantry, a case manager, and they would be able to help with what services are available in that area.
And we also work specifically in Pinellas County because we're funded through the Juvenile Welfare Board. And the same thing, families can call into 211 and they get screened through 211. For our specific criteria for our programs. and then they would be connected to us.
Two more questions. One is, oh, now three. Hey, it's coming. Keep them coming. This is good. We have one specifically, I believe, for you, Dr. McPherson, from Jody Lee, saying, I love that you're doing a relationship group for teens. I do an unhealthy relationship group for domestic violence victims at Spark through Zoom. My question is, and maybe you can either answer this now or feel free to reach out to Jody independently. But my question is, has Spark reached out from their education team to do some workshops on healthy teen dating, sexual and domestic violence at Girls Inc.? So it looks like Spark and Girls Inc. are wanting to partner and connect.
That's a wonderful thing. Actually, we do a lot of referring back to Spark. Again, I head up the family strengthening program. And so the person they would need to be in touch with would be the program director. Her name is Jamie. Her last name is Katrine, Katrein. And she would be more than happy to be the link between Spark. I believe she used to work at Spark at one point, I believe, if I'm correct. And more than happy, we love working with our community partners in any way we can to strengthen this whole entire community. So I'd get a hold of Jamie Katrine as the answer. They're at that main number.
Perfect. All right. The next one, I believe, is for you, Carolyn. What do you think about rapid resolution therapy? Is it effective?
Well, a rapid resolution therapy is one theoretical or intervention that's out there for treating trauma. I have done some trainings with rapid resolution. I think that is it effective depends on the clinician and the client's needs. I always think that trauma and the word rapid don't really go together as far as intervention. So it would, if it's clinically warranted, but there's lots of different ways to be able to work with people. Rapid resolution is one of them.
Excellent. Well, then other than that, we just have a couple thank yous. So in the questions, someone put in thank you so much, and they're going to research. And then another individual said it's been an interesting subject. Thank you for the information. And trauma is a topic people should be more aware of and a better understanding of. So positive marks all around. So thank you, everyone. And I just want to say we've had over 100 participants that were listening in on this. And there's a lot of power in that. And so honestly, you all as the community have a lot of power and authority being able to spread this message and make it alive. We had a couple individuals and a couple groups that we shared here, but every single one of your programs has the capacity and the strength to be able to be implementing, even some of these practices, start small and build up, or go big, either way. So again, I want to honestly thank all of you for spending our morning with us, I hope you took something in. And then lastly, when we close out, there will be a survey. I strongly encourage you to fill that information out to help us understand better about the work happening in our community. And to let you know, we're not letting you off the hook. In about 3 months or so, we're going to send you a follow-up email asking everyone to share how they've implemented any of these strategies. Because again, I think there's at least one thing that each and every one of us can be doing to put this in. So we got a little homework. Sometime between now and about 3 months from now, please work to implement at least something into your work, whether it's a change in practices, a change in understanding, a change in education and information. Please implement this all, because the more we can do being a trauma-informed care organization and community, the better the people in our community are served. So that's all I can say. Thank you all very much for your time and your services. And again, please fill out that survey. Have a good one.